For the last session, in case you guys weren't involved, we have some email questions that we'll get through, and then we'll try to. I promise we're not ignoring the chat. We're just, like I said, we're trying to get used to this whole virtual thing. So we'll also try to cover some of the chat questions as well. I know some of you guys were taking care of the questions as we went along. And so I guess I'll actually start with Stephen Tay. That's a great question in the chat. I'll start with that question. Does an increased severity of a symptom indicate an ongoing recurrence? And I don't know if either Dr. Poon or Dr. Abbatemarco want to start with this and answer that question, and I'm happy to weigh in as well.
Sure. So it depends. Sometimes, more often, we think of increasing severity as maybe not necessarily a recurrence, but it could be. It depends on what the previous symptoms were. And we think of recurrence of previous symptoms as more of environmental factors, possible infection, or what is called pseudo-relapse. But one of the things about demyelinating disease, though, is that it's reasonable to get reevaluated, depending on how severe the symptoms compared to previous. Increases in, like great increases in severity should be reevaluated.
Yeah, and I would echo that. And I will tell you, when I talk with my patients, the simple answer is it depends. I oftentimes see in my patients with spinal cord injuries that the weakness is really the presenting symptom, but in the back end, the pain and the spasticity really kind of transitions over to that, and that's more of kind of the course of the disease. So it doesn't always mean that you're necessarily having a recurrence or you're having active inflammation in the spinal cord or things like that. Like we touched on last time, a lot of things can flare up the old lesion symptoms, but oftentimes I see it a year out, 2 years out, when the neurogenic pain and the spasticity is really more bothersome. All right, and then Janet, there was a question, and we talked about this a little bit, but what treatments are recommended for someone who has neurogenic bladder? I think you covered that, but if you wouldn't mind maybe kind of rehashing it briefly for us would be great.
So, I think the most important thing is to get a good evaluation. So finding a urologist that can really help you figure out which kind of bladder you have, whether it's upper motor neuron or lower motor neuron. You also need to make sure that your kidneys are safe, because if you're having backup of urine into your kidneys, that's dangerous over the long run. And then once you kind of get figured out whether you have an upper motor neuron or a lower motor neuron bladder, then you can figure out how you need to treat that. And I don't know if, with a spastic bladder, you probably need to look at using medications to relax your bladder. And if you're, just there's a broad spectrum with people with neuroimmune disorders, from, as I said, urgency and frequency to needing to have an intermittent cath program.
Great, thanks. And I'll tell you, sometimes it's very difficult because, if you have a large enough lesion, you can sometimes have a mixed picture where you have both spasticity, but also bladder a flaccid bladder. I'm not sure if plasticity is a word. And oftentimes we'll rely on our urology colleagues to help really parse that out. At the University of Utah, we're incredibly lucky. We have a urologist, Dr. Lynn Herr, who I refer to a lot, and she's fantastic at not only helping answer that question, but helping manage. And so, it's depending on, which one's more severe, that kind of dictates treatment as well. Great. There was Really good question here. I have a 7-year-old granddaughter with transverse myelitis with subsequent spasticity from the hip to toe. Her doctor wants to do Botox, another doctor wants to do surgery on the tendons. What are our thoughts? Dr. Poon or Dr. Abbatemarco, I don't know if you guys wanted to weigh in on this at all.
So I think for it does depend a little bit case by case. It's hard to tell basically from a chat what the case is, but in general, we think of Botox as a trial first is reasonable, and talking to the P&R docs and surgeons is probably the best way to ask why they want to do surgery first in this scenario.
Yeah, I think just to kind of add on to that topic, and I think it's the same approach for pain management. It's a trial and error sometimes, and so it takes some different medications, some different procedures like Botox. But I think we leave surgery as our last resort for all of it, whether it be pain management or spasticity management. But it's going to take a kind of a multidisciplinary team to be able to come up with an answer there.
Yeah, and I would. Sorry, Janet. Go on, Janet.
So I was going to say, if you don't manage the spasticity, if you do surgery, you may be right back where you started from if we haven't managed the spasticity in the first place. So I think, I always opt with let's figure out meds, Botox, whatever, to manage. And even sometimes a baclofen pump, if it's severe enough, can reduce the number of surgeries that you have to have.
Yeah, no, that's great. I completely agree with that. And there's a question for Deb. Years after acute onset of double vision, this person describes substantial difficulty persists, especially with reading. Their visual acuity's okay when that gets tested, but they are having trouble perceiving a difference between things like chat, C-H-A-T, or apostrophe hat, H-A-T. What would be an appropriate way to get help with this?
Unfortunately, because I personally am currently in the process of obtaining my specialty certification with low vision, but I'm not done with it. So I'm afraid that one gets a little too technical beyond what my level of training is right now. What I can say, though, is that it was not my understanding, though I could be incorrect, that double vision was really a symptom of the optic neuritis, the visual conditions associated with neuroimmune disorders. Double vision specifically could be another, occurring disorder or condition happening. I'm not certain that the two correlate.
Yeah, no, and I can tell you, hopefully this answers your question, and it's a very, very good question. If it's a problem specifically related to double vision, if in MOG disorder you have a brainstem lesion, or even in neuromyelitis optica, if the lesion goes up and into the brainstem, which is rare, but it can certainly happen, you definitely can have some diplopia. And generally, I know our neuro-ophthalmologists here at Moran, what they will generally do is wait till the double vision is stable. And then one of the things they can do is put prisms in a pair of glasses, and that kind of refracts things so that it ends up compensating for the double vision. Now, they don't want to do that early on, obviously, because if you're going to improve on your own for a little bit of time, they don't want to overcorrect and then have you have double vision because they've overcorrected. So that's one thing to think about is seeing like a neuro-ophthalmologist or even an ophthalmologist about prisms. And then, depending on if some of it is more related to how you're perceiving, so if it's more of a brain or a cortical issue, then it's really working more with occupational therapy on that. Alrighty, and then Janet, this is a question I think aimed for you. Can you provide suggestions in increasing sex drive in men? Is Clomid one thing you might suggest?
You know, that's out of my area of expertise. I can kind of do basics about that. I'm a pediatric nurse practitioner.
That's okay. That's okay.
So that's out of my...
No, that's okay. And then Aaron Dander, you had a question about quads and hip flexors having a lot of spasms that is hindering walking. And this is a really common this is a very common problem with spasticity, and actually in some patients can be more of the problem than the weakness. You know, it can be a little bit of both, but certainly it is something that can get in the way of your ability to walk. Dr. Clardy, it looks like, got onto the chat. But I agree with that. Things like baclofen, other medications, tizanidine, can be really, really helpful, especially if it's more diffuse. So how we manage this, and I think this, you know, when we're talking about the neurogenic pain and the spasticity management, you know, a lot of it is we use the term trial and error. You know, when I talk to my patients, I'll say, you know, it's not quite like we're taking spaghetti, throwing it at a wall and seeing what sticks, but kind of. And it really does depend on how you respond to medication. So oftentimes something as simple as starting baclofen scheduled during the day can be really helpful, or some of the other medications if you're having side effects with baclofen. The other things to think about though are, you know, especially if you have more of a focal spasticity, doing injections like Botox, especially if you have one limb that's really involved, those Botox injections can be incredibly helpful to loosen up some of those areas of spasticity. And then baclofen pumps are something to think about as well, that I know in our institution, our rehab department helps to manage those. And it really is just kind of figuring out what works, but also making sure that we don't over-treat and run into more problems down the road. Just for instance, you know, some patients with spasticity actually use that to help them pivot and transition from, you know, say their wheelchair over to their bed. And if we got rid of some of the spasticity, they would actually have more trouble making that transfer. And so that's something that we have to be aware and are careful about. And, you know, it is probably one of the things that takes the longest to really nail down is symptomatic management. You know, I think Dr. Poon and Dr. Abbatemarco would probably agree here. When we are seeing patients, really the first thing that we're doing is trying to establish a diagnosis, get you on an immune therapy. Oftentimes that's the easiest part, especially if we say, oh, this looks like, you know, neuromyelitis optica. Okay, here's your treatment. It's really the symptom management that eventually takes precedence over the next 6 to 12 months, but admittedly can take a long time.
I would actually also reiterate what Dr. Clardy has already said, and that is that really emphasizing stretch, and if you're able to bearing weight as well, as part of your rehabilitative program, along with a PTOT or something like that. Botox is helpful, but you do have to be careful because you don't want to take away the tone that allows you to transfer and stuff like that. So everything has to be titrated very slowly.
Yeah. I think this is a real, Nancy, your question in the chat is really good. I've had previous episodes of optic neuritis and recently developed significant loss of your near vision as opposed to overall visual acuity. Could this be the optic neuritis contributing, or is it more aging? Dr. Abbatemarco, if you wanted to weigh in on that a little bit, I'm happy to do so after.
No, absolutely. It's a common question we get in the clinic. I would say we always like to rule out age-related things, right? As we get older, near vision can definitely become impaired, and that is not usually a part of the disease process. And so if, cheaters or glasses are able to correct that, then we wouldn't expect the optic neuritis to be contributing. That being said, it's not it could definitely be contributing a little bit. But I think going after some of those easy things that are easily correctable, such as the cheaters to help with near vision, would be an easy way to approach that. If I don't know if you have any other thoughts there.
Well, just that if the cheaters aren't providing enough correction for you, that would be an area that is still eligible and reasonable for seeking low vision rehabilitation. And that's where that magnification training comes into play.
Yeah, I would echo all of that. Sherry Castle has a question. Any guidance on poor sleep? I'm just reading this real quick. So just kind of, I guess we can touch on sleep in general in many of these conditions. This is definitely a area that can be incredibly bothersome for patients. I mean, the general public, regardless, I think a lot of people have sleeping issues, and then you tack on that some of these rare conditions that have these residual symptoms. And so with optimizing sleep, there's really a couple of things that we absolutely have to take into account. So one of them is what is keeping you awake. And so trying to answer your question here. So if you're having a lot of pain, so if you have a lot of neurogenic pain at night, that's oftentimes when things will flare up. We will really gear your treatment towards treating the neurogenic pain, right? Like, so starting a lot of neurogenic pain agents, or starting a neurogenic pain agent, especially at night, can be very helpful. A lot of them have the side effect of making you tired, which in that case isn't so bad. Amitriptyline and nortriptyline are two medications I will often use because they make you sleepy and they help with nerve pain, although there are a lot of different medications that can be helpful. Some of the questions about, and I know in your question you don't have abnormal leg movements or obstructive sleep apnea, but those are things that are certainly worth looking for. I think it's always a good idea to rule out obstructive sleep apnea, especially because, or sleep apnea in general, because if you have a central nervous system lesion within the brain, you're actually at risk for what's called central sleep apnea, and that's an important thing to make sure we don't miss. As well as restless leg syndrome and things like that, periodic limb movements at night, because those are things that definitely can happen with spinal cord lesions. And if all of those are ruled out and you're having just multiple arousals, it may just be, again, going back to, is it pain that's waking you up? Is it having to wake up at night and use the bathroom? That can definitely be a piece of it, and making sure that you kind of manage your nighttime urinary and bowel routine to make sure that that's not something that's causing symptoms. And spasticity can definitely be a problem that either A, wakes people up, or makes it hard so you can't even roll over. We see this in patients a lot, where it's if I'm laying on my shoulder a little bit funky and my arm's starting to go numb, I can just roll over in bed. But if you have significant spasticity, that may be that much harder. Or if you have significant weakness, that makes it that much harder. And so it really is sitting down and figuring out what is it that's waking you up. And again, that can be tricky, in that I would recommend talking with your provider and really on your end kind of keeping a log almost of what symptoms or what you're experiencing at night. And if it's really none of that, if it's just I'm just waking up, then it just becomes, do we start you on a sleeping medication like trazodone? Could certainly use amitriptyline, things like that. So I hope that answered your question a little bit. And I think Natasha, Dr. Abbatemarco's talk should be available, I believe, that has a lot of the neuropathic pain medications on them. So hopefully they can set you up with that. And then Carolyn Davis, the question is, baclofen the only muscle relaxer that's used in a pump? To my knowledge, it's the only one we use is a baclofen pump. Jan, is that correct?
I'm at different points over the last 25 years, they've tried different medications and pumps, but I'm pretty sure that it's not recommended to put anything besides baclofen in a pump.
Yeah, okay, that was my understanding too, just check. And Dr. Poon, you agree there too? I see you nodding.
Yeah, I think there's been many fit medications tried, but by and far, it's not.
And then Jeannie, you started baclofen, you've been on a low dose since. I would definitely talk with your provider. Generally, we start these medications out, both neurogenic pain medications and medications for spasticity really should be started at a lower dose, even to the point where it's maybe not even effective. And the reason is, baclofen for spasticity or gabapentin is a very common neurogenic pain agent. The maximum dose of gabapentin, for example, is 1,200 milligrams 3 times a day. If I started most people on that, they would just sleep. So we usually start at pretty low doses and kind of ramp them up as tolerated. And that can take some time, but I definitely would talk to your provider about that for sure. I think it's a very important thing to make sure that you're not just started on medications, but kind of titrated to the appropriate dose. And then I'm just skimming. It looks like they're going to make the slides with the proper spelling of the medications. And I'm just making sure we don't, if you guys have more questions, feel free to pop them in. We got a few more minutes. Looks like Dr. Clardy's cleaning up the chat for us. So, so Christine, Christina, you tried baclofen at night twice, both times it made it worse. I have seen patients, and Dr. Poon, Dr. Abbatemarco, I'm sure you can weigh in on this. Sometimes patients, for whatever reason, do seem to, kind of almost have a opposite effect with the medications. If that's the case, I don't have a great explanation for it per se. But that said, I think it's very reasonable to switch you to a different medication or strategy. I don't know, Dr. Poon, if you have any other thoughts.
Yeah,
I think Stephen's.
Yeah.
No, go ahead, Jay.
Oh, okay. So Stephen Tay is asking, do other things kind of more off the counter help? And yeah, so magnesium is one of them that we often ask people to try, and it doesn't have a lot of standard side effects. It's really hard to overdose on magnesium. It can cause some constipation or diarrhea, depending on the person's. And then another thing that Dr. Rose likes to do is quinine, or quinine water. And these are just things that you can try.
Jeannie Matthews, regarding I'm on a low dose of gabapentin. They've discussed increasing this as needed. Concern that taking too much of the medication will slow your improvement. In general, I don't see these medications as anything that will slow down your improvement overall. They're not going to slow any of the kind of physical symptoms, or physical improvement, weakness, things like that from coming back. And in general, I think, one thing to just be cognizant of and think about is you also don't want your pain and your spasticity to get in the way of your improvement. If you can't participate with rehab because frankly, it just hurts too much or you're too tight, that may get in the way of your progress. And the most important piece from a approval standpoint is really that really pushing through and doing physical therapy and working with rehab, and that's the most important piece of regaining as much function as you can. All right, I think we have time for oh, sorry. There was a question about optic neuritis and nerve pain. Sorry, I might have skipped over it in the email or in the chat. Dr. Abbatemarco, if you wanted to weigh in on that, that'd be great.
Yeah. So eye pain is a really usually goes away pretty quickly with treatment with steroids or other kind of therapies such as Flex. It can reoccur. So common stressors, and I use that broadly, can bring that back. Infections that we talked about, heat, so people can feel that discomfort around that eye. It does not usually imply that there is new damage occurring or it's recurrent optic neuritis, especially if it goes away quickly. But if those symptoms are persistent for hours to days, you definitely should reach out to your provider. But in general, the pain around optic neuritis should go away and only reemerge during times of quote unquote stressors, like we talked about.
Great. So we're I think at the mark to move us on. I want to make sure you guys have a chance to meet with our sponsors and exhibitors. And so we'll have you guys move along to the expo session right now. And if you look to the left, it's on the bar there. And we'll plan to have you guys meet with them. And again, apologies. A lot of great questions. It's we could probably be here for hours and still not get to everybody. So we appreciate it, guys. Thank you.